Good morning, good afternoon. Once again, this is Rachel Tobey from the Delta Center for a Thriving Safety Net. I am the co-director of this Robert Wood Johnson Foundation funded initiative that is dedicated to advancing value-based payment in care with primary care and behavioral health providers and the associations that support them. As part of today's webinar, we are responding to a call from our grantees that they are very interested, as are the providers that they represent, in hearing real stories from the ground about value-based payment and care. Today, we are honored to have with us a leader in the community health center field who has been participating in value-based payment and care in two very distinct locations in the country. Jaeson Fournier is here with us today in his current role as Chief Executive Officer for Central Texas Community Health Centers, otherwise known as CommUnityCare. He is also a consultant with the Arizona State University National Safety Net Advancement Center, and as the former CEO of Westside Community Health Services, which was one of the lead FQHCs in the Federally Qualified Health Center Urban Health Network, otherwise known as FUHN, in Minnesota, which was one of the first FQHC-led ACOs in the country. We are delighted to have Jaeson with us, and I do want to remind all attendees that Jaeson, as you can tell, is a very busy professional, and we have assured him that we will try to protect his professional time. And if you have questions that are not answered during this webinar presentation today, we do encourage you to send us at deltacenter@jsi.com any follow-up questions that you might have, and we will collect them and have Jaeson answer them in writing, which we will post on our website, along with the recording and the slide set from this webinar. With that, I have no further ado. I'm going to turn the microphone over to Jaeson, who will take it away. Jaeson, do we have you?
You do, Rachel. Can you hear me okay?
I can.
Great. Well, good afternoon, everyone. Thanks for that introduction, Rachel. And it's my distinct pleasure to spend an hour or so with colleagues from across the 13 states that are participating with the Delta Center, both from behavioral health and from community health center, and really to just chat about my experience in supporting not only the direct community health centers that I've had the privilege of serving, but also at a broader level with partners, and to talk about the experience really on the value-based care reform and payment reform models and initiatives. And so delighted to be able to spend that time with you this afternoon just to chat about that experience. So hopefully you can see the third slide that's up there. I'm controlling them. Rachel, if you can chime in just to make sure that what I just did advanced it, great. Thank you. So as Rachel indicated, my experience spans not only 2 states. I've actually been in 3 Midwestern states. First started in community health centers in the early 2000s in the Chicago market, and then transitioned to Michigan and then to Minnesota. And then most recently in 2017, had an opportunity to join a very large health center in Texas, in Austin, Texas. And I'll chat a little bit further about that a little bit more later on this afternoon. But really, regardless of where I've been within the safety net environment, there are multiple things that I've come to learn, but one of them that's critically important for all of us to recognize is that as I've progressed through my health center experience, I've moved from smaller organizations to larger organizations and more complex. But really, regardless of the size of the entity that you may be supporting or working with, either through as an association or a direct service provider, the challenges really have been the same, and the opportunities therein have been the same as well. And so a lot of this is about how we as safety net providers really embrace those challenges in support of the communities we're so privileged to serve. So how do we look at that? And one of the things across all settings that I've really, it wasn't a hard learning, but it was an important learning, is really figuring out how do we leverage partnerships, both within the particular environment. So if you're a community health center with brethren community health centers, and for across different entities, if you're working as a community health center with a community-based health organization or a community behavioral health organization, I should say, as well as the other way with mental health providers back to community health centers, and then others, hospital partners, and so many others that we rely on. And so really it's a team effort. So this next slide is really to be provocative, is to really think about how do we as safety net providers and what imperative is there to be opportunistic. All too often we get very comfortable with the status quo, which is okay because it served us, and more importantly, it served the patients and populations and communities we're charged with serving very well. But the reality is things are changing on the healthcare landscape and have been changing for almost the last 5-10 years, depending on your market, and your market's going to be driving some of that change. And so I had the opportunity when I was back in Minnesota to really be at the forefront of this, partly because of the state's perspective in advancing healthcare delivery and specifically value-based models. And this slide was shared very early on into our contemplation of moving towards a value-based initiative within Minnesota as a collective group of health centers by one of my dear colleagues, who's now the executive director, CEO for the Minnesota Association of Community Health Centers, and he just challenged us to think about that. Gentleman's name's Jonathan Watson, and he's obviously a big Apple fan, but think about these two corporations, right? You've got Apple on the left, you've got Kodak on the right. And really, in order to stay relevant, you have to stay on top of what's occurring within your particular environment. In this case, Apple did very well and continues to do very well and continues to be from a market cap perspective, the largest corporation in the world. On the other side, you've got Kodak, who years ago was at the fore of photography and film, but did not see the emerging trends. And I think part of the need for us as safety net providers, as community health centers and community behavioral health organizations, is really to think about how do we continue to serve the missions of our individual entities and those that we support, but at the same time be opportunistic about thinking about innovation and what does innovation mean within our environments. And so I want to take a little bit of time to describe our experience in Minnesota. And I first want to start by indicating that that experience was almost a missed opportunity. And so when we take a look at that, the Medicaid opportunity that occurred within Minnesota from a value-based perspective really was rooted before the Affordable Care Act took root, and actually went ahead and was advancing some of the value-based initiatives through CMS and its Innovation Center on the Medicare side, and encouraging states to consider innovation. In Minnesota, the legislation really started in 2008, but really in 2010, there was a directive to the Medicaid program to go ahead and start testing, piloting value-based care initiatives. And more specifically, they really wanted to take a look at how do you encourage Medicaid providers to go ahead and reduce the overall cost of the program as a whole, improve the quality of the care, and then increase satisfaction, right? Which aligns, of course, with the AAA elements. And what the state of Minnesota then did in response to this legislation was, with CMS support, they went ahead and set up a demonstration program known as the Healthcare Delivery System Demonstration Program. In the intervening time from when it was first established in 2012 and actually initiated in 2013, more specifically, the name's changed and now is referred to as the Integrated Health Partnership, or IHPs. And really what this was really the state of Minnesota's Medicaid program going ahead and looking at how do we actually test an ACO-like construct relative to the Medicaid population, with the ultimate goal of lowering costs and actually, to a certain extent, getting those costs to plateau and really keep them plateaued so that future spend would be lowered, but also looking at ways to encourage provider and healthcare entities to participate. one of the unique attributes I do want to point out is that the Medicaid program in Minnesota decided that it was going to accomplish its ACO construct through direct provider contracting. And so what does that mean? Well, it decided that at least relative to its space and its market, that they wanted to pilot something with direct provider engagement. And so they decoupled the program in the demonstration from the Medicaid managed care organization. So they went straight to the providers. And so when you take a look at the results that have occurred on this next slide, you can see that from 2012 through 2017, and these are estimates that the state of Minnesota has put out there, but over the course of the almost 5 years that the program was up and running, with 2017 really being the estimates, there was $277 million that was saved by that Medicaid program. Of additional note is $92 million actually directly flowed to the providers given the arrangements that were constructed underneath the integrated health partnerships in Minnesota. And so really what that integrated health partnership did is it incorporated value-based models, but that allowed providers to go ahead and decide what the interventions would be. They allowed it to occur at a local level, which was advantageous, especially on the safety net side. And then there was the opportunity, and initially it was really just upside only, so shared savings only, but then larger hospital systems were put under a risk gain and loss per payment method as well, where there was the opportunity for the state to recoup if certain metrics weren't being met, and cost metrics being one of the bigger drivers. They also married quality outcomes in the initiative, and they also married, of course, the payment methodology as well. And so you can see just, very early on in 2013, there were only 6 discrete entities that participated. And then you fast forward all the way to 2017, and there were 21 that participated in 2017. Of note, the program has changed. I left Minnesota well, actually it was on June 3rd, and I was in Texas on June 5th. And in the intervening time, the program's evolved to what they're calling the Integrated Health Partnership 2.0. You still have some that are involved in shared savings, shared risk relationships, but those are far fewer, and they've moved into more of a PM-PM care coordination model. And so that continues to evolve in terms of what's going on up in Minnesota as a whole, and I can't speak very intelligently to the current status. But when we talk about what was going on within the safety net system, and specifically within the community health center environment in Minnesota, really this was almost a missed opportunity for us as a collective group. We are and were very, and when I say we, I'm talking collectively as community health centers, really representing only my perspective though in that regard. We're very comfortable though with our existing payment model, right? Prospective payment system, and the way that we function as a whole on both the Medicaid and Medicare side. And so the thought as a community health center of drifting away from that without some type of reassurances is very daunting for us. And it was back in 2012 when we contemplated what this could look like. Well, it was almost a missed opportunity for the health centers in Minnesota, simply because at that point in time, both CMS and the Medicaid administration in Minnesota really did not think you can have an ACO construct without having a hospital at the core or hospital system at the core and involved. So fortunately, though, through the Minnesota Association of Community Health Centers and their leadership, they'd already started stoking the fire within health centers about thinking about what value-based initiatives could look like and how health centers might be able to participate in that. And that actually happened through a very formal process. So if you're with a state agency that supports mental health providers or community health centers, your role is critically important in helping us as your members and as folks that you support, really advancing our thoughts in terms of how we participate with value-based. Quite honestly, I don't think we as a collective group in Minnesota would have moved forward and really even paid attention to what was happening had our association not drawn our attention and essentially beat us over the head and said, this is coming, you got to think about what you're going to do and what you want to do, and really apprised us as their members about what healthcare reform in Minnesota at that point in time meant for us. and actually led us through a strategic contemplation in terms of how we might get involved and what it meant for us to collaborate as individual FQHCs around the table, as well as collaborate as a system of care. And part of that was done very deliberately through a strategic planning process with their members and really teeing that up and having us think about, well, should you consider being managed service organizations or coming together? And I'm sure some of the states on the phone are very aware of that, or through independent physician associations, whatever it may be. So different structures. What was clear through the work that was done with the association was that only really one of the community health centers, and there were 17 community health centers across the state of Minnesota at that point in time, only one of them was positioned to actually be able to have the volume to draw and be able to negotiate favorable either value-based relationships or just contracts, frankly, overall. And that happened to be the community health center that I supported up in the Twin Cities in St. Paul, specifically Westside Community Health Services, which is now Minnesota CommunityCare. So there was enough patience there for us to go out as an individual entity and negotiate contracts. But then there was also, from a reality check perspective, there was a recognition that, hey, we really need to, if we're going to move forward down this path, we need to do it as a collective group. And it's not always easy to do that. So when we take a look at the reality check, really for us, we needed to push back to the state as a collective group and say, hey, we might want to play in this space. We're not quite sure if we want to play in this space. But with that in mind, we want to have the option. So we pushed back and said, what about a virtual ACO construct that doesn't require hospital involvement or participation directly? Decouple it from that and really put an emphasis on primary care, because we felt like community health centers, just like our brethren on the mental health, behavioral health side, are very well positioned to actually deliver on value-based. And we went through that process. Fortunately, the state was receptive to that, and they were able to get CMS to agree as part of the pilot to allow that to happen. And so really it would have been a missed opportunity had we not had that legwork done within the association and as pure health centers. And so what ended up happening is the conversation, very frankly, that occurred is, well, who's going to participate? And, you know, the impetus outside the Twin Cities was very different than within the Twin Cities. And the reason that being is there was much more competition in the Twin Cities, not only for our existing patient populations, but with the future of Medicaid expansion coming in into the state, just like it has in so many other states, our patient populations as historically served were going to be seen as being attractive to other healthcare providers. So 10 of the 12 community health centers in the Twin Cities decided to come together. And we decided that it was actually, you know, there were three options. You can not get on the bus, essentially, and go down this value-based. You can be on the bus and drive the bus, preferably, or you can be under the bus, right? And so when we took a look at this, we decided we certainly did not want to be under the bus. And so the collective will of the group was as well, let's throw our hat in the ring and let's respond and become one of the state's first value-based integrated health partnership. And so we ended up becoming one of the first 6 that participated in the program. And we used a vehicle that was available to us, but we repurposed 501c3 and named it the Federally Qualified Health Center Urban Health Network, or FUHN. And so what is FUHN? So for those of you that might not be familiar with this acronym, it really is the collective 10 Minneapolis and St. Paul federally qualified health centers that came together. The same 10 are still at the table together, working together. We really were the very first FQHC-led and FQHC-only safety net Medicaid accountable care organization in the country. Of course, that's progressed in the intervening time. And you can see the participant organizations that are still around the table at FUHN. The interesting thing is I was putting this presentation together just as an aside is that almost 6 or 7 of them now have new logos, and they all look much better than they once did. So it was kind of interesting as I was putting the presentation just to see that. And so when you take a look at FUHN as a whole, it continues to grow in terms of service and doing a great job as individual health centers, as a collective. But in 2017, there were about 110,000 unique patients served through those FQHCs in the Twin Cities. And they represented about 40 service delivery sites in that market, very diverse patient population like so many other safety net providers. 41% served in a language other than English, very diverse, 91%, very poor, 95% under 200% of federal poverty. And in 2017, about 50% Medicaid, still 28% uninsured, even though Minnesota still, at that point in time and today, has the lowest uninsured rate in the country. And then services, as you would expect for a community health center, especially a network as large as FUHN, are very diverse and a lot of activity occurring within. So as I continue to talk about FUHN, I just want to pause here and really kind of challenge you as either direct providers in the Delta Center's supporting in the various different states, or as entities that have the privilege of supporting entities that are involved in this space, is to really think about what game you're playing, right? So for all community health centers, for all community behavioral health organizations, the healthcare landscape just continues to change. I think one thing for certain we all know in healthcare is change is not only coming, it's here, and it's going to continue for some time. And then you overlay that with, you know, the disruptors, or what folks are putting out there as disruptors, the Amazons, the Googles, the Apples, and how they're starting to play in the space. You know, Amazon going ahead and recently taking over a 340B distributor and putting it into their mix has implications that are far-reaching, and trying to understand all of that can be very intimidating, especially when you're a smaller safety net provider who's just trying to make sure folks in your local community are able to connect with the care they need and deserve. And so for us, you really, you know, as a collective group, we need to be thinking about, you know, what game are we playing? We're used to playing checkers for the most part, right? We maintain our mission of serving the underserved. We're comfortable with that. We know the payment schemes. We can understand the budgetary implications. It's much, much more tricky to go ahead and play 3DHS. You know, how do you anticipate the move from one platform or playing level to another? How do you anticipate future moves? And the other image down at the bottom is again, to be provocative, is to think, here's a beautiful picture of not quite Minnesota. It looks kind of like it's from somewhere out in the Rockies, maybe in Washington or Oregon for the folks that are sitting on the phone, maybe from those states. A beautiful scene. You've got a dock and you've got a boat, right? But you've probably heard this analogy. For many of us on the provider side, relative to value-based, the issue is we're on the dock right now. We're used to playing checkers. We're used to getting paid a certain way. It's fee-for-service, and we're trying to play two different games at once, right? You're trying to play the volume game, and how do you go ahead and decide the value, right? And so that dock is very safe and comfortable, but the boat is attractive. I want to get on that boat, get a little closer to the mountains, but I'm uncertain. So it's almost like you've got, maybe you're still only on the dock. Maybe you've got 1 foot on the dock, 1 foot in the boat. If you're there, you're trying to figure out what's your next move. And maybe you're in the boat, depending on your market. But you've got to be very much aware of what's happening within your environment, and then what is your next move moving forward. So coming back to FUHN in the Twin Cities. So one of the things that ended up happening for us as a collective group of 10 CEOs sitting around the table and our staff and thinking about, why do we want to do this? And really, when we looked at the integrated health partnership or the healthcare delivery system opportunity through the state and Minnesota Medicaid program, it was really about an opportunity for us, one, to leverage resources and much needed resources for our communities and the patients we serve. There's also an opportunity for us to collectively collaborate in a way that we've never done before. So to foster collaboration, and then at the heart of it also was the opportunity to learn together. So collaboration is one thing. The other is to learn and to grow and learn from each other. And one of the things that I think has been fun success over the years is that this wasn't just, and I'll talk a little bit about the governance structure, but this wasn't just CEOs sitting around a table. We actively engaged purposely and deliberately with our staff. And I think that's one of the greatest success that this endeavor has had for FUHN as a collective group, is that we embedded structures that actually allowed, even with changeover in CEOs like myself, for it to persist. And so I think that's extremely important when you look at the populations, communities we serve, and the entities that are involved. And so one of the things that needs to be recognized is that when you're coming together as partners in collaboration, be it a behavioral health provider with a community health center or a group of both coming together, although you may be similarly minded, mission-oriented, making sure that folks in your communities get the services they need, the reality is the motivations may be different. But really the common thread for each one of the health centers was really taking a look at, not only is change coming, but there's also a survival threat, right? If we just sit on our hands and we do nothing and we stay comfortable with what we know, i.e. we stay comfortable playing checkers, we might not be around to serve our patients into the future. So how do we take a look at this? So there was that survival threat to organizational integrity. And most importantly, how do we make sure that we're not only positioned for the next year or 2 years, but for the next 50 years to serve the historic populations that we've served, and make sure that we're well positioned to not only endure with that service, but to optimize and increase and provide more comprehensive services as a whole. So at the end, it came down to an individual choice, right, for each health center. Should I jump on, push off the dock, and get the foot in this boat or not? I don't know if I'm going to be all in. It might be easier just to jump in with some of the larger health systems that were going down, and by the way, that was happening in our market. You better believe there were health systems that were saying, hey, we might be doing this. Do you want to join us? Not. And so there were overtures made to several of the health centers in this. And what we decided was that besides the collaboration, we had natural alignment. We're mission-oriented. We are dedicated to underserved communities. We have community-based governance. We were in a defined geographic area, which made it easier. But we also were motivated by addressing social justice issues and social determinants. Could you guys, Rachel, are you still able to hear me?
Yes, you went blank for just a second, but we can hear you now.
Yeah, I apologize. It's going through, there was a forward from my landline, so sorry, I thought we had that blocked. So sorry to all the participants. So really about partnership alignment, it was one of the things. So when I took a look at it with my peers at Westside Community Health Center services, we really need to look at what were the motivators. And we had multiple motivators. The outside motivators, increased competition, which I've already talked about, irritated payers who really thought that outcomes for the community health centers, which were not risk adjusted, and still aren't risk adjusted adequately, were not what they needed to be. And so when we took a look at that, there was pressures from the outside saying you're not an effective group of providers. And so how do we demonstrate that? It was a way for us to take control of telling our story and really to demonstrate that we are a value, that we're high value health centers. And then internally, it came down for us at Westside to think about, making sure we stayed relevant within a dynamically changing marketplace. It allowed us an opportunity to contemplate, what does care transformation mean for us and for our patient populations? Most importantly, how do we move away from just treating health disparities each and every day, but to garner in resources that allow us to move more midstream and upstream along the social determinants paradigm to actually start addressing health inequities? And what did that mean for us? And that meant being able to leverage in resources that we might not otherwise have to go ahead and allow us to do things we might not be able to do otherwise. And then there was both extrinsic and intrinsic reasons, right? We needed to take a look at how we better share information across community health centers. How do we ingest information like claims information and use that to augment? We only knew what was going on within our four walls for the most part. And so how do you take information that's from outside your own system and incorporate that so that you're engaging and activating your patients and populations into their own healthcare very differently? These were all things that were motivators for us, and I'm very happy to report that a lot of that turned out to be true. And so when you look, and I have an updated slide on I updated this one. When I looked at it, it should really say Partnership is messy and hard and fun. And no pun intended, well, pun intended, I guess. But when you take a look at this, you know, as a very large health center, we were twice the size of the second largest participant in FUHN through Westside. I would get questions as a large health center, why don't you just go alone? Why bother? And I'm providing my insight as it relates to the discussions that we were having. You know, why bother doing this? It's a lot harder to do something in collaboration, isn't it? And, you know, I get questions from staff. Why are we doing this? What's in it for us? What's in it for me? And so really rooted at the core of a lot of discussions around the FUHN table that always provided us true north, both within the entity, the community health center that I directly support at Westside Community Health Services, but also within FUHN itself was a strong belief that we're stronger together and that we can do great things by working under a collaboration, really that power of partnership. But then there was the question, but aren't we competitors? Like we had, there were health centers that were literally within a couple blocks of each other. And so the thing that helped us overcome that is really just a true recognition that we can think that we're competitors, but the needs are so great, and they still are, that if you enhance your systems in a value-based initiative and you demonstrate that you're effective to not only payers but to patients, you've really gone ahead and demonstrated that you're a resource to the community at large and you've positioned yourself for success. And so really that fundamental recognition that there's more patients than we could ever meet the need for, and that it was really an opportunity to come together and strengthen our system of care. And I think that's really something that stops a lot of community health centers and behavioral health providers from collaborating. They really just, you know, I can't share my secret sauce because we're competitors. And so that's part of this. And so if you want to get to that finish line, you got to get a little muddy in thinking about this, right? And so part of what we needed to do was we needed to commit to the what. We needed to understand why we were doing it, but to commit to the process that was going to be ahead of us. And that was extremely important for us. And so really it boiled down to us very much recognizing that as a collective group of 10 health centers, we needed to undergo clinical practice transformation. And that transformation, once we committed to it, was going to be around people, process, and technology. And we really didn't know what the how was going to be necessarily, not out of the gate. That was part of the learning process. And actually, that was some of the most valuable aspect of it and the sharing that occurred. And so when we took a look at, and if you take a look at FUHN as just as a how, their how, and it's just an example as a whole, is really looking at how you infuse across disparate entities change management techniques. We're all struggling with the same thing, so why not learn together? And then one of the things that we put into place as a core building block was each one of the health centers needed to embrace patient-centered medical home. In Minnesota, that's called the healthcare home certification. But we also needed to recognize what we didn't know and what our expertise wasn't in. And our expertise was not in large data analytics, e-health technologies. How do you go ahead and develop stratification of your patients and populations? What about attribution? How do you actually accomplish exchange of information across disparate entities and then ingest that information to actually make informed decisions, not only on the point of care side, but also on the care coordination side. And then we needed to set very, very clear clinical interventions. And we looked first and foremost to where the value was going to be, because at the end of the day, there was financial wins for us as a collective group, and we wanted to line along that. And so we looked at some of the low-hanging fruit and what were the opportunities, and one that emerged fairly quickly was some work relative to ED utilization, which doesn't surprise anyone on here. On this call, the other is we core to what we were trying to do is reinvigorate care coordination. What does that look like? How do we take lean process improvement into account and look at our workflow processes to make sure that that's happening? How do we make sure that we're engaging with patients who are receptive to change, so motivational interviewing, and they're really hardwiring across disparate community health centers some work processes while maintaining autonomy but setting some expectations that you're going to do pre-visit planning and what does that look like. And it wasn't across the board. Not all 10 health centers did the exact same thing. I'd be lying to you if I said 2 of them did the same thing. That wasn't the case. We recognized the uniqueness of each one of our partners and really about providing resources. And then we needed to understand what was going outside our four walls and recognizing that the opportunity was only based on understanding what was occurring outside our own environment. And so initially in 2013, when the project started, FUHN had 24,000 unique individuals attributable. By 2015, that expanded to 32,000, and it represented about 55% of FUHN's overall participating health centers as it relates to their overall patient population. So not everyone there was exclusion criteria, there was timing issues, continuity of Medicaid for individuals, and there was a shift from a 12-month attribution to a 24-month attribution as well, and that happened in 2015, and that was partly accounts for the expansion in numbers, but also Medicaid expansion that occurred in 2014. Then you can see at the bottom of the slide that the total cost of care assigned to the 24,000 initially, and this was baseline spend, right? And then it had to be adjusted based on the number of folks, but you at least got it to a PMPY or per member per year spend rate on a total cost of care TCOC side, and it was $175 million. Not everything was included. One of the things excluded, and we negotiated this, is we didn't want inpatient mental health hospitalizations. Folks who have psychiatric conditions are in need of that care, and we did not want to go ahead and A, be responsible for it, and B, recognize that we weren't going to really effectuate change with that. And so about $35 million was pulled out of the overall spend, and you can see how it was broken down. 100% of all pharmacy claims, almost all outpatient claims was involved professional services, so you get a good sense. So how did FUHN do? And I think the way I would answer that is exceptionally well. The opportunity was there, but what you see here is that each year, 2013, 14, 15, progressively, FUHN directly received payments as an entity and then distributed down to participating health centers, millions of dollars. There was almost a little bit over $8.3 million of savings that came back to FUHN in 3 years. So from a financial perspective, those were monies that were not coming. And I should clarify, by the way, we did not put our prospective payment system payments at risk in this arrangement. And so that was monies in addition to our typical Medicaid payments. So a little bit over $17 million total saved for the state, and again, the savings that came to us. What you also see on the left-hand side of this particular slide is the percentage decrease in total cost of care. So by the third year in 2015 of the demonstration, almost 6% of total cost of care saved as a result of the initiatives. And that was annualized. In the first year, we were able to achieve a little bit over 3%. And the threshold to gain access to savings as the provider portion of this was hitting at least 2%. What's really dramatic and exceptional is really what you see on the right-hand side, which is the drop in 3 years from baseline in 2012 of 1,062 ED visits per 1,000 individuals, and dropping it to 773. The collective group of health centers lowered it by 27%. And really, I think what my colleagues that were very early on into this process would communicate to you, and this is a quote, not mine, this is Mike. So I served as a board chair for FUHN for 5 years and the treasurer for a year before I decided to move to Texas. But my vice chair for the first 5 years was a colleague at University Health Care Center in Minneapolis. And this is her quote. And she'd been in FQHCs in the Twin Cities for 20 plus years as FUHN came together. And, she very eloquently said, we went from fierce competitors to extreme collaborators. And we did it not because it was necessarily the right thing to do, although I would assert that it absolutely was. We did it because we were being opportunistic, and we realized we were stronger together. And so that's part of it. So how did we achieve our results? Well, it really about how do we leverage in things that we might not otherwise be able to do as a collective group. And that was really, how do we get actionable data in the hands of our care providers and our care teams? And so we needed to develop a robust analytic system, be able to ingest the claims data, recognize those opportunities, understand what's going on outside our four walls of the individual health centers, and then couple that to a robust care coordination program. And we recognized very early on that we needed an infusion and investment to help with this. We also needed to have a partner that was going to go ahead and support our analytic needs. And so we sought out an administrative partner, and through a competitive process, ended up selecting Optum. And Optum then came in, provided the help we needed, analytic support, and they also infused money. And so there was a relationship that was struck that when we gained, they gained. But frankly, up front, they went ahead and put their own money at risk, and they bet on us with no guarantee of a return. And so that's something that's very atypical. If you know Optum, you know they're part of United Health Group and United Healthcare. And one of the things you probably know about them is they're not, they're very, very protective of their resources. They've got a lot of it, but they don't make too many bad investments, right? And so we were able to shake them loose of some cash to help with this, but they bet on us because there was learnings for them as well. And, you know, fortunately it worked out well for them and for us. So how did we achieve the results that we did? Well, we, with our help from our partners at Optum, were able to create identification and stratification tools that informed our care teams and our care initiatives. And then we really used Lean across the health centers. And you can see down at the bottom, I'm not going to describe these. I know the slides are going to be shared with you, but we really emphasized triple aim plus one. And so the typical triple aim plus an emphasis on primary care services. And then I coupled this to care coordination as well. And then we really had robust engagement from our clinical leaders across some chief medical officers and medical directors and others, quality improvement folks, really engaged heavily in the project. And as a result of that, there was standardized clinical policies that happened, for example, in terms of how we treat middle ear infections, which we were surprised to see. We had kiddos that were showing up to emergency rooms, and there were simple solutions that we can put into place. The other thing, as you're contemplating this, is we really fostered a collaborative model relative to decision-making. It wasn't like myself and my peer CEO said, this is the way we're going to do this. We really set up a structure from a governance perspective that allowed it, while not democratic necessarily, but it allowed for input from all various different levels within the entities that were going to be impacted. And so we really set it up, and our program director initially was from Optum and then transitioned into, FUHN now has a chief operating officer who really goes ahead and spends a lot of time and effort in supporting the work. In terms of long-term sustainability in 2016, FUHN as a whole, so still operating as a ACO today, just under a different construct with the state, but coupled to that in 2016, August 2016, they were one of 51 health center controlled networks awarded funding through the federal government through Health Resources and Service Administration. So took the learnings, ended up replacing the administrative partner with internal resources through the HCCN, and then advancing not just the care model, but overall. So when we take a look at the lessons learned, so as you're contemplating and supporting folks who are thinking about value-based, really when you take a look at that, you really have to set what are the initiatives that will support transformation. And there's a lot of them, and I'm not naming all of them, but people, technology, resources, systems, and intent. The other thing is depending on where you are in Minnesota, there was no upfront investment. The providers had to go it alone. So if you don't have the analytic capability, there isn't good, robust interoperability or health information exchange platform, whatever it may be, then you've got to think about how you do that. Now, fortunately, there's analytic tools that are coming out. Some of them are embedded in our electronic health record systems, but they're very expensive. So you need to think about that. How are you going to do that? Then the real investment is staff time. You got to give people the time to learn. You got to give people time to engage, and then recognizing what you don't know. And then if you don't know something, get the help that you need. And I think that's important. And so things to contemplate is just, best offense, just group of small health centers doing 110,000 patients a year up in Minnesota. You know, for us, best offense was a good defense. And when we thought about that, we wanted to go ahead and say, well, let's get involved because we don't know what the future holds. The other is make sure you're bringing value to the market. Whatever that value is, you get to define, but you get to tell your story based on how successful you are. And then really back to the power of partnership, I think you've got to be willing to take a chance. You've got to step off, preferably with friends who are like-minded to be able to be successful. And so I'm going to turn my attention now to Texas, and I'm going to blow through this a little bit more quickly so that we have a little bit of time for questions. But the entity I'm with now is Central Texas Community Health Centers, doing business as CommUnityCare. We're probably top 30 in the country in terms of overall size for community health centers. We're a very large teaching health center, about 250 residents, family medicine, IEM, internal medicine, pediatrics, OBGYN coming through our doors. We care for about 100,000 unique, a little less than 100,000 unique individuals. About 57% are uninsured. You can see on the slide, 66% of our adults are a very diverse patient population. Gives you a little bit. So everything in Texas is bigger, yes, the saying goes, right? And that also includes the needs on the medical side, partly because Texas has the unfortunate distinction still of having the highest uninsured rate in the country. So I thought it'd be interesting just to kind of put some things into perspective for those on the phone. So the states that are listed here are the states that are participating with the Delta Center. And you can see total population there, uninsured population, and Travis County, which is really CommUnityCare's service area, federally designated service area. We've got about 500,000 folks, a little less than 500,000 folks who are at or below 200% of federal poverty level, about 170,000 who are Medicaid public insurance beneficiaries. But we have about 172,000 individuals who are uninsured. To colleagues who might be on the phone from Maine, you guys are 118,000 uninsured folks. Iowa, 172,000. You know, great support in your states, expanded Medicaid. We don't have that in Texas. And so the needs are significant. You can see, I know our brethren from the mental health here in Texas is participating with Delta Center. And we're confronted with 5 million individuals. So, you know, and the value-based opportunities really are fewer and far between potentially down here because of the uninsured. So really looking at this, so that's the view from 20,000 feet, drilling down to 1,000 feet. You know, we as an entity really embrace data analytics, want to be a data-informed safety net provider. And so we take a look at persistent health inequities within our community. And this is just, we ran a vulnerable population footprint. If you're not familiar with it, I'd encourage you to go to the Engagement Network, which is run under the University of Missouri. Great resource. You can run this for your own communities. And then what we did is we overlaid some information from Behavioral Risk Factor Surveillance Survey on what we identified as the vulnerable population footprint, which for us was anyone who in a geographic area census tract had incomes. Collectively as a population, 20% of the population were in poverty, coupled to 75% or fewer individuals having graduated from high school. While you can see the far right, if you live in our vulnerable population footprint, here in Travis County, you're 2.4 times more likely to lose your teeth than someone who's actually essentially living west of I-35 in the Austin corridor. Some huge, significant disparities. And so as we take a look at CommUnityCare's journey towards when we're caring for 57,000 uninsured individuals, you know, what our patients are navigating is a very complex and fragmented system. And as we're thinking about value-based and have been for some time here at CommUnityCare, what can we do? And so we're really looking at expanded care teams with enhanced responsibilities for all team members, our community health workers, clinical pharmacists, behavioral health therapists, you name it, we're getting everyone involved. And then we need to understand our current resources. The other thing that we're doing that's different than perhaps even FUHN and others have been doing is really trying to take a long-term approach, looking much more longitudinally at our patient populations. And so this next slide really kind of outlines some of the clinical transformation. So the learnings I gained with FUHN and through FUHN in partnership with my colleagues up in Minnesota have translated into what we're trying to do here down in Texas. And it's not just me, my chief medical officer, others. We're already engaged in this work. But when you take a look at this, one of the things we talk about all the time is we want to be patient-centered, but population-focused. And so for us, 100,000 patients or so a year served. But if you fast forward 3 years and you look at 3 years worth of data, it's 160,000 folks. And caring for 160,000 folks is very different than 100,000. And so how do we go ahead and actually build systems that allow us to do that? So this next slide looks very similar to what I had up for FUHN earlier. But really what we're doing here, and I mentioned it, and FUHN was already there, frankly, but when we take a look at this, really what we're emphasizing is tripling +2. So we're still emphasizing primary care services, but we're also looking at enhanced care coordination and patient activation. We're actually talking about how do you actually get to a measure of resource intensity at the individual patient level. And then how do you actually go ahead and aggregate that up to a population for a care team, and then at a clinic, and then at a system of clinics, so that you're able to apportion your resources appropriately to effectuate change long term. And so we're really emphasizing a population health management approach and really thinking about what does that look like, because all too often, like so many other providers, you know, we're always paying attention. We mostly pay attention to who's in front of us and who's on our reports. And most reports are maybe 12 months or 18 months. And so how do we go ahead and take a longer term view? And that's part of what we're doing. So down at the bottom, there's a question here. So why would CommUnityCare go ahead and do all of this if there aren't really value-based opportunities here in Texas? Well, there are, just they're not the ones that you would think. For us as a community health center right now, there's almost very little on the Medicaid side and the Medicaid ACO side, although there's some movement occurring there. It's very nascent comparative to certainly the Minnesota market and other areas across the country. Most of the initiatives have actually been, believe it or not, on the uninsured side because we have local indigent care programs, local hospital districts, depending where you are. That's not across Texas as a whole. But then Texas also has an 1115 waiver known as the Delivery System Reform Incentive Payment. So the Texas Healthcare Transformation Quality Improvement that allows us to draw down federal funds. And so, again, we don't want to be under the bus. We want to go ahead and make sure that we're positioning ourselves to be ready for the change that's happening and will continue to happen in our area. And even more so, but as importantly, we need to have partners to do this. And this is a list of a group of partners that we work pretty closely with here in Travis County and in Austin, Texas, to make sure that we're caring for the communities we serve 380,000, 400,000 times a year. And so what does that look like? And so, you know, this dock, you know, again, everything's bigger in Texas, right? Longer dock, bigger dock, more boats, and that. But we have to be reliant on more partners around the table. So when we take a look at this, CommUnityCare is absolutely in this game. We're trying to think about where do we need to be in a year or 2, 3 years, and how do we leverage in local partnerships here as a very large safety net provider, and how do we go ahead? So, you know, the picture down at the bottom is pretty representative. We've gone off the dock to a certain degree. We're in the water, we're swimming, we're still getting oxygen, but we're chasing the boat. And partly because the marketplace isn't necessarily where we need it to be in order for us to do this collectively. So our energies and focus right now are actually on the uninsured. And this year we're projecting about $10 million to come our way. That's at risk. We might not earn it. We have to earn it. And there's 27 different clinical outcome measures that we need to go ahead and achieve in order to fully realize that, but 10 million is there. We also have a indigent care agreement, local indigent care agreement, where there's 4 million in per member per month payments that are directly tied to outcomes, pay for performance outcomes, 2 million there, and then alternative visits. We've been able to negotiate relative to nurse visits, community health worker visits, and that 4.1 million there. So about 20 million out of our $110 million budget is coming through value-based arrangements, and we believe more to come. So I alluded to this a little bit earlier. We're really aligning our resources toward longer-term outcomes. And so as you think that MAP is of all of our patients, Austin's kind of in the middle of that. And when we look at longer-term outcomes, we're really trying to go ahead and work not only with the local indigent care program and our partner, and we're directly linked with the hospital district here, Central Health or Travis County Healthcare District. We're a public entity community health center. But as we take a look at this, one of the things we're doing with our partners is to say some of the things we're working on actually aren't going to reap benefits in the next 6 months, 12 months. So how do we start looking at effectuating change, especially when we have folks in our community who are dying 10, 15 years younger than others? And so how do we get credit for those efforts, and how do you track that? And so that's where the population health management side comes into it. And so it's really taking both the long-term game approach and the short-term game, and you really need to be thinking about that. And I think that's one of the things that's going to lead us as safety net providers not only to continue to be successful, but actually demonstrate our success and value to those out in the communities we serve. And then final thoughts. This is provocative. These are questions I think you should be asking yourself. And I know I'm a little bit past time here, so I want to open it up to questions, Rachel. So I'll let folks kind of read this and allow the questions just to flow because that's my last slide.
Wonderful. Well, thank you, Jason, for both, sort of two distinct stories with some common themes, as well as some very provocative questions for us all to continue to think on. I do want to encourage folks who are online and may not be able to voice your question that there is a chat box that you can access by hovering over the bottom of your webinar window and then clicking on the speech bubble icon. We have received some questions, and I will do the ones that we have time for, but we encourage you also to continue to submit additional questions that you may have to deltacenter@jsi.com. And as promised, we will collect and forward those to Jason to get responses that we will post alongside the recording of this webinar as well as the slide set. So Jason, one of the questions that has come in is just asking for some clarification about what you meant by repurposing the 501c3 when discussing funds structure and the lessons learned.
Yeah, absolutely. So great question. Yeah, and I can imagine being in the audience and hearing that, and it's like, what's he talking about? So there was an existing 501c3 in the Twin Cities for which 5 of the 10 FQHCs were participating. It was called the Neighborhood Healthcare Network. And actually that's truly FUHN's entity's name. It's Neighborhood Healthcare Network. And it was really an IT support entity helping with shared deployment of an EMR and a practice management system, and it included non-FQHCs. And the decision was made that entity was no longer going to function to that end. And rather than create a different and a new 501c3, we just repurposed that one and updated our articles of incorporation and changed an existing entity. So it expedited it by a little bit, but not by that much.
Great. Well, thank you. I do want to respect people's time as we near the top of the hour. I also want to let folks know that if you want more information about the story of FUHN, JSI has recently published a case study on that FQHC-led accountable care organization, and we encourage you to check that out. We will also make sure to send that or post that alongside the information of this webinar in case folks are wanting more information. I want to thank everybody for attending today, and to Jason especially for taking time out of his busy schedule to share both of these stories with us. Thank you all. And once again, if there are additional questions, please do not hesitate to email deltacenter@jsi.com, and we will make sure to get your questions answered. With that, I will bid everybody farewell. Thank you for joining.
Thanks, Rachel.